Hi, thank you for joining us today. I'm Melissa Banton. I'm the Director of Breast Cancer Survivorship at Johns Hopkins. Today we're joined by Don Dizon. He's an oncologist specializing in women's cancer at Lifespan Cancer Institute. He's the Director of Medical Oncology at Rhode Island Hospital. He has an interest in survivorship with a specific interest in sexual health. Dr. Dizon, thank you for joining us.
Thank you very much for having me.
Today we're going to talk a little bit about sexuality and intimacy during and after cancer. So to start, can you tell me a little bit about some of the issues cancer patients face during treatment, after treatment, regarding sexual function?
Right. What's so interesting about the field of sexual health is that so many of the issues in this arena seem to have started before their cancer diagnosis. But when women are diagnosed with breast cancer, it's the furthest thing from their mind, and they just don't want to talk about it. The immediacy of the diagnosis, the fear that they might actually die of this cancer, and really needing to understand the next steps, take first and foremost parts of it. So even as we talk about medical therapy after the diagnosis has been established, and we talk about the side effects of treatments, medical oncologists still don't really bring up the sexual health side effects because it's so private and personal, we don't want to assume things. As a result, we don't have a great sense of what the sexual health concerns are from the point of diagnosis. What I can tell you is that from talking to women either during treatment or immediately following treatment or even a year out after treatment, the major issue they can't come in with is a lack of desire, just that this sense that they really are just not interested in anything sexual. When you dig deeper, it doesn't seem like this has ever been a primary issue. It's more of a secondary problem, either because strained relations with their partner about how to move on, changes in their body image by the mere fact they had surgery, by the loss of hair from chemotherapy, and then accelerated menopausal symptoms for women who are still menstruating at the time of diagnosis. These are big traumas to their body, and they're still trying to adjust to it. But as a result, any attempt at penetration can be very difficult. Even wearing anything that rubs up against their vagina and their pelvic organs can cause chafing, can be very uncomfortable. And I always explain to women, you know, if something is uncomfortable, or let's go to the extreme, very painful, you won't want to do that again.
Sure.
So that's why the desire issue becomes so important to them, but tracing it backwards is really important. So from when women are getting treated, it's all wrapped up in menopausal types of symptoms. The vaginal dryness can really predict who's going to have a trouble doing any kind of sexual activity. And I'm also seeing a lot of lack of orgasm in this population, which I find incredibly fascinating, because when I see women who are, say, treated for a pelvic cancer or even a rectal cancer, orgasm tends to be intact.
Interesting.
Yeah.
So a couple things that come to mind when you bring that up. You mentioned low libido. Mm-hmm. If you see a patient that presents with low libido, it sounds like it's a combination of medical and psychosocial for a lot of these patients. How do you treat that?
Well, low libido is very complicated because it's exactly that. It's the epitome of the mind and body working together to either suppress desire or, in very rare cases, just completely dissociate the libido from the experience of sexuality and intimacy. The approach is very complicated. My style is to try to identify an issue that can be actually treated. So if it is menopausal symptoms, we can approach that and we can give them vaginal moisturizers. We can talk about vaginal estrogen. We can talk about certain solutions and the importance of lubrication and lubricants during any kind of intercourse. If it's body image issues, you know, there's really great data now that psychological counseling to approach the mind's interpretation of how she's viewing her body can be very powerful. Group therapy can be a very powerful maneuver as well. And then when it comes down to it, if it's intimacy is the reason why desire is lacking, then I do try very hard to meet with both the partner as well as the patient, and try to get them on the same page in 3 arenas in sexual health. Sort of, I ask each of them to, not in front of me, but maybe in a private conversation, because it's a very difficult one. What do you need right now? What do you want right now? And where do you wish you were right now?
Tough questions.
Very tough and very private questions,
Sure.
but we don't have a roadmap how to navigate sexual health after cancer. And certainly, it's not a roadmap we as oncologists were ever trained to navigate patients through. And quite frankly, I have a very open-ended conversation with patients, so I'm prepared to hear just about anything that they want to talk about.
Sure.
I can't say the same thing for my colleagues, and that's okay, because we all approach this with our own schema.
Sure.
And I can't tell my colleagues to adopt an open schema if they're just not willing to do that.
So you bring up a lot of good points. Your colleagues, and sort of how do you broach that question? If a patient is really suffering, do you recommend that she talk to her medical providers, or how do you go about that?
You know what I found most interesting about that is as long as the resource is there, my colleagues are okay bringing it up. What I think is the most interesting thing about this is when patients have brought up the issue, historically, it's been let's just see where things go, and then move back on to cancer, and move back on to treatment, and let's just redirect the conversation to ground that I think is important. She may not, or he may not, but I do think this is an important area. So then they go to their nurse and their infusion nurse or their navigator, and those are the ones who are really the front lines of this. But there have been 2 experiences, well actually 3 experiences that I've had bringing a sexual health program into a cancer center, and one was in breast, one was in women's cancers, and then one was with partnering with folks at the MGH to bring a sexual health service line to bone marrow transplant survivors. And what was interesting about all 3 experiences, once my colleagues knew the resource existed, they were the ones to say, oh, by the way, you were treated with radiation. Are you having any problems? And they would say, yes, I have the perfect person for you to see. That seems to be the key. My concern is we both know community settings may not have this resource. It's not that common at all to see an oncologist adopt this as an area of interest, let alone start a program. But more and more, I think there are people within the community who are willing to have these conversations with these patients. It's just a matter of identifying them.
Sure. I want to circle back for a second. You mentioned a few minutes ago about vaginal dryness. So let's talk a little bit about that. What do you recommend for a patient that's really suffering? You mentioned discomfort, vaginal discomfort. What would you tell a patient that has some of those issues?
Vaginal dryness is actually a very common issue for all patients who are treated with cancer, actually, but it is a major problem after treatment for breast cancer, particularly because of the therapies we prescribe. I try to take vaginal dryness and what's now known as the genitourinary symptoms of menopause, or GSM, out of the picture of sexual health and make it really a general health issue. And in that regard, my aim is not to divorce it completely from sexual health, but to make it something that women feel is part of their daily regimen, just to maintain skin health or healthy hair, or a healthy vagina needs to be looked at in that viewpoint. A couple of things are important. So vaginal moisturizers are very important, and oftentimes when oncologists say you should use a vaginal moisturizer, they don't actually tell them much more than that. So how do I use it? How frequent? So I'm pretty specific. Use it at night because it tends to leak out if you try to walk around with it. And use it 4 to 5 times a week, and even 1 hour before intercourse. There are various preparations, so we go through that. And then most importantly, I make sure they understand it's not a lubricant. So a moisturizer, vaginal health, a lubricant, sex play.
Okay.
Lubricant you should use when you're going to do an activity in the bedroom. Moisturizers really are about healthy behaviors, promoting a healthy vagina and pelvic organs. The second part can be a little bit more tricky. And I tend to use this part of the conversation after someone has tried vaginal moisturizers and maybe hasn't responded too much. But I do talk about vaginal estrogen preparations, which are very different from taking estrogen by mouth, for example. Multiple groups, including now the American Society of Clinical Oncology and the American College of Obstetrics and Gynecology, they looked at the data, have concluded you can safely use a vaginal estrogen even if your breast cancer was hormone receptor positive, because the doses, especially today, are so low that the effect is local and very low risk of systemic absorption. And there's been no data to show that influences recurrence or survival after breast cancer, but the impact can be big. Having said that, I have patients who really don't want to do a hormonal preparation. For those folks, it's not my job to say you should do this.
Sure.
If they say I'm not comfortable, we let it go. If they say I'd use it, if the other thing didn't work, then that's how we do it. And if they say this is so bothersome to me, can we start here? I'm perfectly comfortable doing that.
You mentioned patients struggling with the inability to have an orgasm. Can you talk a little bit about why that may occur, and are there tips that you give a patient who may be really struggling, who may not have had issues in the past, but now find themselves really struggling with that?
Yeah, that's a very difficult issue to try to address. What I found is once treatment is ended, there's such pressure that either a woman will place on herself, quite frankly, or she's perceiving this pressure from her partner to be normal again. And so this quest of not new normal, but the old normal is really where a lot of this seems to be grounded from. So it is not uncommon for me to meet women who say, I used to be able to achieve an orgasm, when someone just walked in the room or the wind was a certain way and it was that easy for me. But now 45 minutes later and I'm chafing and it's still not. So the first thing I tell them is like, well, if you're doing it to the point of chafing, you should probably stop. It's sort of give your body time to heal, and you should attempt it only when you feel like you want to. Your body will read you, and that's a really important thing. To follow the cues of your own body is important. It's not to say that this is all in someone's quote mind, but it is a mind-body connection when it comes to orgasm. And what is more common than even when someone is able to orgasm is that the intensity isn't as high as it once was before, or it does take longer. I try to put a more positive light on that. It's like, instead of things that you're now missing, think of what cancer didn't take from you. And if you're starting with this baseline, give it some time and things can come back. Part of this is also, we now have described this new term from Jennifer Goss did most of this work of breast-specific sensuality, and it turns out there's a loss of that. 10-20% of women, even after a lumpectomy, will lose breast-specific sensuality. Most patients, that was a huge erogenous zone for them, and they haven't been able to find another part of their body that will make up for that loss. And part of it is because no one's asked them to try. It's like, you could explore this and see if something's happened to other parts of your body. You might have heightened sensitivity elsewhere that can also help you reestablish orgasm. But tincture of time, there's no magic pill that's going to help that.
You mentioned exploration. Do you ever recommend to patients that they experiment with relationship aids or other types of devices that may help with the inability to achieve an orgasm naturally?
Well, what I found is, and this is something I'm actually aiming to study more formally, because there's a lot of literature about intimacy exercises and how that can help couples reconnect after medical illness. So I like to start folks at that point. When I talk about sexual health with survivors, I use a picture of an on and off switch to illustrate men.
Sure.
Because if men are excited and erect, then they're ready.
Yep.
Women don't operate that. Women are more of a computer board, you know, with all the wiring and all the switches, and you know, now you introduce cancer to that, and the switchboard's not working, but the man's on and off switch is fine. There's a disconnect.
Sure.
And that's a very difficult territory to to either have a conversation about, let alone try to work through. So there's this thing called Sensei Focusing that I like to provide to patients, and it's all about play. And I like to use that word specifically when I talk about it, because both male or female partner, male or female patient with breast cancer can walk away with the same message from me: work on play. And it's really to sort of de-stress that intimacy and intercourse are the same thing, because it's not, especially not for women.
Right.
So Sensei Focusing is just a structured exercise of touch that requires one to read the other person's body and how they're accepting sensations, and it holds off intercourse until the very end. And what I've seen in the best case scenario is a reestablishment of intimacy with the side effect that intercourse is again pleasurable. But it's that really just reestablishing intimacy so that both folks are on the same page about what that means to them is probably some of the best help I can give.
Sounds like a really good way to get reconnected or to connect.
Absolutely, absolutely.
For patients that are interested in learning more about that, is that a term you can Google, or are there resources online available?
There are absolutely resources online about it. There's not a lot of data on Sensei Focusing in women and men treated for cancer. It's ripe for research that I'm hoping to get started. But yeah, it's very much available online.
Good to know. Would you have a sense of how prevalent sexual dysfunction is after breast cancer? Is there good data out there?
You know, there is good data, but it's not consistent data, and the reason is very basic. Depends on how you ask the question.
Okay.
So depending on how you ask that question, 50 to 100% of patients.
Wow, that's a big span.
It's a huge span, but and what's more interesting that I've found is that even if the issue exists, not everybody feels it needs to be treated. So there are folks in sexual health who may not come from an oncology background, but really invested time and effort and energy into helping women and men treated for cancer lead better sexual lives. They might come into this arena with the feeling that everyone should see a sexual health specialist. Everyone deserves a sex life. What I've learned is the only person who can tell me if they want a better sex life or a sex life at all is the person who's gone through that experience. And it is not uncommon for patients not to show up after they've been referred to me.
Right.
It's not uncommon at all. And I think it just reflects that 50 to 100% is a huge spread. But where they rank their sexual life in, you know, the important issues that we all face after a cancer diagnosis, I think is what's gonna determine whether they seek help for it.
Interesting.
Yeah.
And it doesn't sound like it's a one-time thing, that it may be something that a patient struggles with on the continuum.
Yes, absolutely. So there are folks who just come in for that one visit and feel the education has been so helpful that they walk away with a better understanding of what's happened to their bodies.
Sure.
I think that's nice. They may not want to come to see me again, but in practice, I oftentimes will say, why don't we touch bases another 4 weeks, 6 weeks, 8 weeks, 12. And what's even as common is I refer on. I refer to sex therapy. I refer to pelvic rehab. You know, so it does take a village, even in this one little area of survivorship, to get people to the help they require.
I think you bring up a good point about pelvic rehab. Can you talk a little bit about what that is?
Yeah, absolutely. So pelvic rehabilitation takes what I do to a much greater level. Pelvic rehabilitation is done by physical therapists who are specially trained in looking at the pelvic musculature and seeing if there are areas of heightened sensitivity or pain triggers. And what they do is a specialized massage into the pelvic musculature. They can provide biofeedback exercises. And the whole goal is to help relax the musculature that tends to be either spasmodic or contracted as some of these causes.
So it sounds like someone would need to be really specialized. This wouldn't be the type of physical therapist you'd go to for, let's say, an orthopedic issue. Is that right?
That's correct. And it is very different from, say, lymphedema specialists.
Sure.
I try to go with someone who has actually that experience, not only in pelvic rehab, but pelvic rehabilitation for patients treated for cancer.
Good point.
Yeah.
For patients who, I've had patients come to me and say, it's my partner who's really struggling. Do you work with both the patient and the partner? And what advice do you give to partners who are sort of saying, I want my wife back, I want my partner back, and she's crying and she's not into this?
Right. You know what's so interesting about that? When I first started this field, I was all about just treating, because I started this field as a women's cancers sexual health specialist. So when I opened my first program, I was specifically only going to see seeing women. Right. I was not interested in seeing their partners. That is probably a mistake because the sexual life of a person is in a large part determined by what that relationship looks like.
Right.
So it is not uncommon at all for women to come in and say either, you need to help me have sex because I don't want my husband to leave me, or if we don't have sex every Tuesday, he's going to know something's wrong. You know, and so there's all these issues. And the other really important thing that I try to impart to my colleagues as to why you have to do this in the context of cancer is because I'm not a feminist in that room. So I don't it's not my job to tell women, do not have painful intercourse. Do not let yourself be in a situation where you're being forced to have intercourse. Well, I believe those things greatly. Sure. But this is a trauma that a couple has just experienced, and they're both trying to make it through intact. So I don't judge a woman who says, you know, I have to have this sex because he'll leave me otherwise. That's a real phenomenon of worry and pain. And she's sacrificing her own comfort for the sanctity of a relationship. My goal is to make it less of a sacrifice and less of a job, and get it to what it was before, which was fun and playful. To do that, I have to incorporate the spouse. And it's easier for a spouse to understand what's happening if they know it's grounded in something real. So much of this might be perceived as, I don't understand why you can't. Why can't you relax? Why does it hurt? Can't you just relax? And I'm the one to tell the partner, no, she can't tell her vagina to relax. It's going to do what it wants to do. Right. But it can relax. So I'm the one to say, I don't want you to have intercourse for the next 6 weeks. Instead, I want you to play, or I want you to do this exercise on Sensei Focusing. And I use a term that's very medical sounding so that he'll buy into it. You know? But so often, it's the partner that gets more out of the education than the patient, because the patient knows something's off. She just can't explain it. The partner is just confused about it. Sure. And what I found was even more interesting, it doesn't matter if it's a same-sex couple or a heterosexual couple, the misunderstanding exists.
Interesting.
Yeah, it's been very eye-opening.
I get a lot of questions from patients about what is normal in terms of regards to how many times a week we should be having sex or how many times per month. And how do you answer that question?
So I answer the question with some great work my friend Barbara Anderson did in Ohio State. So she developed this concept of a schema. And the schema is how you view your own sexuality. And it's through the prism of how you were raised and how your parents had their own sex life. It's your church, it's your community, and it's your past experiences. And all these congregate together and tell you, this is my schema, and this is what's normal for me. So the nice thing about that is there is no one normal.
It's not about checking the box.
It's really
for the
not
Tuesday.
about checking the box. You know, you're going to have two folks or a couple, they might be very comfortable having intercourse 8 times a week. They have that schema. It's very open and expressive. You have another couple who liked out, fully clothed once a month, and we're happy with that. You know what? And both of them are okay. I think the hardest situation for me to come in, or not hardest, but most awkward situation is when someone comes to see me because they've been told that their sex life isn't normal. That, you know, you should be having intercourse. I know you guys like to play, but you should be having intercourse. And the fact you can't have intercourse is a problem. And it's a lot of just, you know what, it's okay. You can own that because it's not a problem. It's your schema, and it's all right. As long as you're happy, he's not asking for more than you're willing to do, you guys are okay.
I like that. It's a good way to look at it.
Yeah, and I think it's a nice way even to explain it to our colleagues who maybe don't want to talk about this. Because they often find, if I talk about it, I'm going to have to delve into it. I'm going to have to get the, you know, well, how often is that happening, and what makes it better? What makes
Very
it
clinical,
worse?
very medicalized.
Very medicalized, and they're just not ready to do it. I'm like, you know what? That's your schema.
Yeah.
And your schema is not only influenced by all of these other things, it's influenced by the fact that you are a clinician providing cancer care. And that's all right. This is not in your thing. But, you know, I'm sure there was a time when you couldn't imagine talking to someone about their bowel movements, you know, and how much watery stools are you having in a day? That's a very private thing to talk about someone. But we do it because we know our drugs cause diarrhea. Well, you know what? Your drugs are causing sexual dysfunction.
That's a great way to look at it.
You ask that one question, you refer it on, you say, you know what, I'm not the person you can talk about this to, but we'll find you someone.
And what's that question? Is it, how's your sex life? Or how do you phrase it?
Well, how I phrase it, okay, so it's what's interesting in my clinic, because I also see patients who with cancer, I actually don't do the deep dive into their sexual lives when I see them for a chemo visit or even a checkup to see if they're still doing well. So I do it in the sort of the implicit model, this permission, give limited information, provide specific suggestions, and then refer on to intensive therapy. I ask for the permission. And the way I generally phrase it is, depending on the scenario, you know, some of my patients who take this medication find it very difficult to have intercourse. I'm wondering if that's something that's happening for you. Or you can ask just simply, you know, I make it a practice to ask everyone one question about their sex life. You know, how's it going? You know.
And when's the right time to ask that question?
Yeah, that's the big question, isn't it? Yeah. So what I'm trying to, my sense is that you want to open the door to the discussion as early as possible, even if they're not ready to. Because as long as patients know the door was open, they'll walk through it when they're ready. So in an ideal world, it would be one of the first things you ask a patient when you meet them. You know, it's like, you know, you do a gyne history, so how many kids do you have? Did you have any miscarriages? You know, is your partner, you know, do you have sex with men, women, or both? How long have you been married? You know, are you married to a man or a woman? Da, da, da. You know, not that you need to now, but if it ever comes up and something's going on in your sex life, I want you to know I'm open to it, discussing it with you. And they'll either walk through the door at that time, or they're going to remember you said it.
Planting the seed, it sounds like.
Planting the seed in the very beginning, as early as possible, as early as comfortable. It may not be during the time when you're giving the first diagnosis, or you're talking about first chemotherapy, or talking about that clinical trial, but soon after, it's just something that should be mentioned.
Those are great tips.
Thanks.
How do you approach patients with metastatic breast cancer? Do you treat them any differently?
You know, what's so interesting about that question is, at one of my former places of employment, because I've had several, one
one of my colleagues came up to me and asked me that exact question, sort of, I have a woman, she has breast cancer, it's gone to her liver, but she really wants to be able to have comfortable sex again. Who should I send her to? And I'm like, well, you know, I do run the sexual health clinic here. She's like, oh, I thought you only treated women who are cured.
Wow.
Yeah, so there is this perception, and it's one that I actually wrote a column about for ASCO Connection, that women with metastatic disease should be not only grateful to be alive, that should be the only thing they care about. And more often than not, and it's kind of sad to me, women refer themselves to my clinic after their brain mets.
Wow.
Or after they've been diagnosed with liver mets. And they do it outside of their oncology visits. And I don't know if it's because they're almost too afraid of what the answer will be if they ask for the consult, like, oh, you shouldn't worry about that. Or they're just, you know, maybe in a way embarrassed that they even want this, when there's so many more important things to do. So yes, I do see those patients. And it comes in two really, really incredible sort of scenarios. One is the more common, which is, you know, I might have metastatic disease, but I won't let my sexual life be another thing I give up.
Great.
So help me work on this. And I meet with both of them, her and her partner, to see how we can get on the same page about this and how we can move forward on that. But the other one is a little bit harder, and it's one that I've actually employed helpless psychotherapists about. And it's the situation where a patient has metastatic disease, maybe at one point got very sick and was hospitalized, maybe for a long time, and came out and reestablished a normal baseline or a new normal baseline. But the husband or the partner just remembers that sickness, and there's a switch where the partner no longer sees a spouse or a romantic person. He sees a patient, and he's adopted the role of caregiver. That's harder to deal with. I've tried to do Sensei Focusing in that scenario, but I've also referred to couples counseling. I think it's incredibly important to work through that, because a woman who's living with metastatic disease might have her times when she feels like a patient, but she's going to have a lot of times when she feels like a person. And when she feels like a person, she wants to be treated like that person.
Right.
But on the other end of that is the person who supports her, who sees both, and may not be able to make such an easy adjustment.
For patients that want to learn more, are there resources online? Are there credible websites? Where can we send patients that really want to sort of dive more into this?
Well, you know, there are more and more, there are some folks who are declaring themselves interested in learning about this, which I think is fantastic. Online right now, Leslie Shover, who's been at MD Anderson, has created a wonderful, comprehensive web-based program called Will to Love, Will number 2, LOVE.com. And it's partnered with the American Cancer Society to evaluate this toolkit in real time for patients, and they can actually enroll on a clinical trial to evaluate Will to Love through the ACS website. And I think it gives you access to information, and we can learn how useful it is through your experience with Will to Love. So that's one. Living Beyond Breast Cancer, Young Survival Coalition, both have great resources on sexual health. And there are two societies that I think will be well served from the clinician's perspective, the Sexual Medicine Society in North America and the International Society for the Study of Women's Sexual Health, ISWISH and SMSNA. They have members all across the US, and accessing one of those members would be great. For anyone whose staff want to get more education about this, I developed and helped run something we're calling the Oncology Sexual Health First Responders course. as part of the National Consortium of Breast Centers meeting in Vegas each year. And it's just that. It's a crash course on theory and approach and treatments. And it happens over the course of a half day. And I think that's a nice way to just get a flavor of what we do in real time.
Wonderful, really great suggestions.
Great.
Dr. Dizon, thank you so much for all this great information.
Well, it's always wonderful to see you.
Thank you too. Thank you for joining us as well.